Hey, guys.
Hi.
Yes.
All right. Okay. So do that. That on.
So simple as that.
We want to review and exit full screen. Yeah. All right. Got that. Okay. All right. So what's on tap today? Two topics. Share out here. Come on. Okay. There we go. So two things, right? Total parenteral nutrition, which is basically giving the patient a diet through IV, and then diabetes. So we're going to start with a discussion of diabetes, and then we're going to take a break, and then we're going to move into total parenteral nutrition. Okay. So with that said, let's cue that up. Diabetes. Okay, so let me get that for you. Diabetes parenteral. I'm going to put both of these in chat, and I'll also send them to you. Put chat up here. Drop these in. Come on. Do it like this. Come on. Slow. Kill my video feed. Maybe it'll speed up. Come on, kiddo. Kill the feed. There we go. That's better. This. Yeah. All right. So now. Documents. There one. That. Diabetes. Yeah. So both parenteral nutrition and diabetes notes should be in chat now for you. Let's that here. Diabetes. Yeah. There we go. Bing, 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 bing. Yes, that's the one we want. All right, good. All right, so pull this over here. All right. So when we're talking about diabetes, all right, we're talking about a condition in which you have excessive amounts of urination. Okay. And there's different reasons that that happens. Okay. One reason is a class of diabetes disorders called diabetes mellitus, in which is difficult to control your blood sugar because of problems with insulin. And the other is one called diabetes insipidus, which is a separate type of problem having to do with a hormone called antidiuretic hormone. Okay, so we're going to learn about actually both of these today. So pull this up. Share. And there we go. All right. So one of the things that can happen in managing your blood sugar, right, is that we can have problems with the functioning of an organ called the pancreas. Okay. The pancreas job as an endocrine organ is to release a hormone called insulin when your blood sugar levels go up, which is a signal to your body to remove sugar from the blood and use it for energy. Okay. So that's where we are able to take in carbohydrate and then steal the energy from that and use it to make ATP. Okay. The liver also responds to insulin by turning blood sugar into fat and into something called glycogen. And the effect of both of those actions is to reduce blood sugar levels. Okay. And if you eat a balanced diet, that generally goes off without any trouble. Okay. So, what can sometimes happen in a condition called diabetes mellitus, okay, pull a pen up here. DM stands for diabetes mellitus. Okay. Is that the body can either lose the ability to make insulin because the cells in the pancreas that do that job get killed by the patient's own immune system. And that's called an autoimmune disorder. Okay. So in type 1 DM, okay, we have an autoimmune attack.
This gonna be like the
I didn't know it was.
she ain't know I was gonna come up here with.
So your immune system, for reasons that we don't understand, okay, turns around
Okay.
and
Can you mute yourself?
it turns around and it destroys cells in the pancreas called beta islet cells. Beta islet. Okay. So the beta islet cells get destroyed, and then the patient can't make any more insulin. All right. In type 2 diabetes mellitus, type 2, type 2 DM, you have insulin insensitivity. Okay. Which means that over time, your body loses the ability to listen to the insulin signal. In both cases, all right, what happens is you end up with a resting blood glucose of over 200 milligram per deciliter of blood and a fasting blood glucose of over 100 to 126 milligram per deciliter. Okay. If you're heading towards diabetes, say type 2, then you're going to have a resting blood glucose of between 140 to 199. All right. Now, why might you be heading towards type 2 diabetes? Well, one of the contributing factors to diabetes mellitus is a sedentary lifestyle, meaning that you eat a lot of calories and don't do a lot of exercise. And then the result of that is that when your blood sugar levels are high all the time, right? High RBG, okay, and that leads to insulin resistance. And what that means is that over time, the receptors for insulin, which are little surface proteins on your cells and tissues, fewer and fewer of them get made. So eventually what happens is that the insulin is there in the blood, knocking on the door, trying to tell your cells there's sugar there, and the cells don't answer, right? The result of that is that your blood sugar levels climb and climb and climb, okay? What does this do? Well, with a lot of sugar in the blood, one of the things that happens is that your blood volume goes up, okay? And the reason that your blood volume goes up is because water moves from your tissues into your blood, because that extra sugar pulls the water in through osmosis, okay? So your blood volume goes up, all right? Your blood volume goes up and your blood pressure goes up. Blood volume goes up, blood pressure goes up, okay? What does that do? That puts you at increased risk for cardiovascular disease, is at least to hypertension, and that puts strain on the heart. It leaves you to increased risk of blindness, okay, and decreased nerve function. Now, why is that? Well, because the high blood pressure damages capillary beds. They can burst and blood can leak out. And then everything that gets fed by that capillary bed starts to die, right? The retina of your eye is an example, right? The retina of your eye is where we turn light into electrical information that our brain interprets as vision. And so if you burst the capillaries that feed the little photoreceptors that do that work, then you can't see anymore, right? The photoreceptors die, and even though light's coming into your eye, you got no way to get the information back to your brain. Okay. And unfortunately, once that happens, that's a permanent condition. because nerve cells don't grow back. Okay. Decreased nerve function. Well, that has to do with, again, reduced blood flow to the nerves because you do things like a ruptured capillary beds, or you have poor flow to the nerves. The first thing you'll have is something called neuropathy, right? Where you'll have a lot of pain. And then what'll happen is that the nerves will die and you won't feel anything from there anymore. And the danger with that is with reduced blood flow and reduced pain is that you can get injuries and infections in those areas, and those tissues can die. Okay, they can become what's called necrotic. And then what'll happen sometimes is that we'll have to amputate those areas. Things like legs and arms may have to come off. Okay, because we can't let necrotic tissue stay attached to your body, because then the infection will spread through the blood and can kill you. Okay. Kidney failure can happen because of the high blood pressure and the extra work that the kidney has to do putting the extra sugar from the filtrate, which will eventually be urine, back into the blood. Kidneys have to work real hard to do that. And that sort of stresses them out, right? In addition to the fact that when you're working with high blood pressure, you damage the filtration part of the kidney, right? There's little capillaries where the blood that flows into the kidney gets filtered, and that filtrate, that liquid, is eventually what's going to become pee. Okay. And what happens when you have all this extra pressure is that you start leaking stuff into what's going to be your pee that shouldn't be there, like protein and blood cells and other stuff. Okay. And so you start to lose a lot of nutrients and a lot of important components in the blood. Okay. So the kidney loses its ability to do its job, which is basically to clean the blood, to maintain the blood pressure, and to maintain fluid and electrolyte balance and body pH. Okay. If your kidneys go, if both of your kidneys go and you don't do anything about it, I think we talked about this, you have like 2 days to live. Okay. Because you're going to get so much junk in your blood that you're going to screw up protein function, and you're going to destroy membrane potential. And that means that your nerves and your muscles aren't going to work right anymore. Okay. So kidney failure, right? That's another result. You'll be disoriented. And that's because, again, you're destroying nerve cells and nerve connections. Okay. And this is likely going to shorten your life. Okay. So the goal of dealing with diabetes mellitus is to control blood glucose levels by making healthier lifestyle choices. So the thing that's different about a normal person, which is what's shown here, right? This is normal blood glucose levels before and after a meal, right? But in a diabetic who's not controlling their diet or their insulin levels, what happens is that you have breakfast and up goes your blood sugar, and it stays up. And then maybe you have lunch and your blood sugar goes up even more. And then you have dinner and it just goes up and up and up and up and up. Okay. That's because you're not using the insulin to do its job. Okay. So the different types we've kind of already talked about, right? In type 1 diabetes, what happens is that for reasons we don't understand, okay, you have an autoimmune attack on the pancreas that destroys beta islet cells, and you can't make any more insulin. So the fix for this is to take insulin. Okay. Now, is that a cure? Not really. Okay. It's sort of a stopgap measure. Okay. It's like patching your tire, right? It'll keep the air in the tire, but eventually you're going to want to replace the tire. Okay. The only permanent fix for this would be to replace the pancreas, right? And we don't really do that very effectively. There's not really a good way to do that. And even if we did that, it's entirely possible that the immune system would turn around and destroy the new beta islet cells. Okay. So what we would have to do is put you on immune suppressants in order to keep that from happening. And that would increase the likelihood that you would get an infection and get real sick. Okay. So that's the same problem you face in all autoimmune diseases. There are a lot of autoimmune diseases. Okay. There's things like lupus. Okay. There's Graves' disease. There's rheumatoid arthritis. Just abbreviate that ARTH for short. Rheumatoid arthritis. Okay. And I'm trying to think of some others. Well, type 2 diabetes. Type 2 D or type 1 DM, type 1 DM, not type 2, type 1 DM. Yeah. There's a lot of others. Okay. The reasons this happened, we don't really understand. Okay. There's a lot of theories out there. Okay. Some think that there's a mutation in either the tissue or the immune system, and you end up making either an unusual antigen or an antibody that react and result in destruction of tissue. Others think that immune cells that are normally inactive become active for reasons we don't understand and turn around and attack your own tissues. And then another theory out there is that you get exposed to something that's similar but not identical to your own antigens, and you make a whole bunch of white blood cells that can effectively attack and kill that antigen, but then they end up cross-reacting with your own antigens. And it could be a combination of all of those. Okay. We don't really know, but it's a unfortunate event when it happens, because the only way we can deal with it now is to knock down the entire immune system, as opposed to just going after the white blood cells that are causing the trouble. Okay. Which is bad, but that's where we are. Okay. In type 2 diabetes, all right, what happens is that your lifestyle and your diet lead to all these problems associated with being resistant to your own insulin secretion. So your insulin levels don't really fall. In fact, they may even increase, right? So you're going to have insulin levels that are either normal or high, insulin elevated or normal, right? But it doesn't make any difference because your cells aren't listening to your insulin. So how do we fix that? Well, we change your lifestyle, right? And we can also give you drugs that increase your sensitivity to your own insulin. So ultimately, you've got to live your way out of this. Okay. So is it reversible? In many cases, yes. Is type 1 reversible? Not really. Okay. What are some other problems that you see with people that don't control their blood sugar? Well, you have excessive urination. That's what diabetes means, right? So you're losing a lot of water, which means you also have excessive thirst, right? And that's a condition called polydipsia. Polydipsia. Okay. Excessive urination, diabetes, is sometimes referred to as polyuria. You'll have sugar in the urine, which we call glycosuria. And because your body can't use the sugar in your blood for energy, you're instead going to go to your fat in your body and burn that to try to make ATP. And that produces molecules called ketone bodies. And that ends up in your pee, and that's ketonuria. Okay. And those acids will also cause a drop in your body pH. And we call that acidosis. In this case, the specific acidosis is called ketoacidosis. Okay. There are even some diets that try to make this happen by restricting your carb intake and having you only eat fat and protein. Things like South Beach and Atkins do that. In the short term, what this does is it vaporizes your body fat and turns it into these ketone bodies that you pee out, you breathe out, you sweat out. Okay. So initially you'll lose that fat weight. The problem is that if you go back and put carb back into your diet, you'll gain all that weight back real quick. Okay. The other problem, of course, is that if you stay in ketoacidosis too long, then what happens is that you can go into a coma and you can die. A coma and death. Coma and death. Okay. So that's not good. Okay. So this is why we have to control the blood sugar in these people. Okay. And we have to do that by changing their exercise routine and by changing what they eat. Okay. In gestational diabetes, what happens is that the pregnant mother's placenta, which is the connection between the baby and the mother's blood supply, ends up soaking up all the insulin that she makes. And so she becomes insensitive to her own insulin and her blood sugar levels begin to rise. Okay. And the reason she's insensitive is because her insulin's getting mopped up. Okay. So the fix for that is that during the pregnancy, we can give insulin. Okay. But the ultimate fix is to have the baby. Because once you have the baby, the placenta's gone and her insulin sensitivity should go back to normal, right? The risk, though, is that the mother could develop DM type 2 later in life. Okay. That's a special case. Okay. So that's gestational. What are some risks? Okay. Well, if we don't control blood glucose levels, we could have preeclampsia. We have to have birth by C-section. The baby's birth weight may be really high. You could have high blood sugar in the infant hyperglycemia. Infant could die. And you could have maternal hypertension and diabetes mellitus for the mother after the pregnancy. Okay. And preeclampsia, what happens is the connection between the baby and the mother is threatened. Okay. And if that occurs, if that exchange between the mother and the baby's blood is cut off, then the baby's going to die. Okay. So one of the risks with diabetes mellitus, if you're treating it, is something called hypoglycemia. If you take too much insulin or you don't eat enough food, your blood sugar can fall, right? If your blood sugar falls to 70, we have to take immediate action, okay? If we see levels hovering around 70, we might look at symptoms like shakiness, mental confusion, sweating and palpitation. I would sum this up as weak in the knees. If feel like you just want to collapse. Okay. Weak in the knees. Okay. All right. How do you fix it? Yeah, you have carb around, right? So there's glucose paste that you can carry. You can carry candy. Okay. You want to give that, and you want to retest blood sugar in about 15 minutes. Okay. And if it's still less than 70, repeat, give more. Okay. Once the levels get back to where they should be, more carb and protein or a tiny meal will help. Okay. And it doesn't matter when the next meal is going to be, their normal next meal, and you just administer. Okay. With hyperglycemia, blood sugar levels are above the expected range, and this can come from improper diet, improper use of meds, improper activity levels, and an inadequate amount of insulin production, or increased number of cells that are insulin resistant. Okay. You'll see a blood sugar greater than 220. You'll see ketonuria. You'll see polydipsia. And of course, you'll see polyuria, right? Increased frequency of urination. And the reason for the polyuria, of course, is that there's sugar in the pee that pulls more water into the pee. And that means that you have a greater volume of urine that's going to be made, right? You want to consult a provider or go to the ER. Take the med if you've forgotten to take the med. Okay. Long-term problems include the Somogy phenomenon, where we have morning hyperglycemia in response to overnight hypoglycemia. Okay. Get a high sugar snack and appropriate insulin dose to prevent this. The dawn phenomenon is an elevation of blood sugar around 5 to 6 in the morning, results from an overnight release of growth hormone from the pituitary gland, and it's treated by increasing the amount of insulin provided during overnight hours. Okay, so there's different kinds of insulin that you can take. You have to either inject it or take it as a nasal inhalant. There's fast acting, okay, and there's slow acting insulin. All right. And what a diabetic will learn to do is to take a combination of the fast and slow acting insulin that will sustain them for a long enough period of time that they can get a good night's sleep in. Okay. As well as, of course, administering insulin during the day. So generally, when you get an insulin injection, you combine these two, okay, in a way that the fast acting goes in first in the injection and the slow acting follows it, right? Sort of like a time release deal. So let's take a look at diabetes mellitus.
Diabetes mellitus is a complex disorder of metabolism. It is a disease in which the body does not produce or properly use insulin. Insulin is a hormone that is needed to convert sugar, starches, and other food into energy needed for daily life. There are two types of diabetes that affect the elderly. Type 1 diabetes, also known as insulin-dependent diabetes mellitus, IDDM, or juvenile onset diabetes, results from the body's failure to produce insulin. An individual with type 1 diabetes needs to take daily insulin injections for the rest of their lives. It is estimated that 850,000 to 1.5 million Americans have type 1 diabetes. Non-insulin dependent diabetes mellitus, or adult onset diabetes, results from insulin resistance combined with relative insulin deficiency. Approximately 16 million Americans have type 2 diabetes. Someone with type 2 diabetes might make healthy or even high levels of insulin, but obesity makes the body resistant to its effect. Exercising 30 minutes a day and maintaining proper body weight for age and body type can help prevent type 2 diabetes. Prediabetes occurs when a person's blood glucose levels are higher than normal, but not high enough for a diagnosis of type 2 diabetes. Without lifestyle changes, most people who have prediabetes will progress to type 2 diabetes within 10 years. The diagnosis of DM can shorten the average lifespan by up to 15 years. By 2025, over 20 million Americans are expected to have diabetes.
Now, another type of diabetes is diabetes insipidus. Has a completely different cause, okay? But it still results in polydipsia and polyuria, excessive thirst and excessive urination, okay? So let's take a look at diabetes insipidus.
Good morning, everybody. Today I'm going to do a quick YouTube video on diabetes insipidus. And I'm so excited because I'm back to tutoring guys on YouTube. YouTube videos are really fun, and it's a break from Skyping or FaceTiming or everything else that I do. So diabetes insipidus, if you brought the REMAR review package, this is in your homework book, okay? And it is on page 13. So if you have your homework book, get it out, and you can do it with me, and you don't have to do it for homework on your own. Now, I've noticed a huge trend when it comes to diabetes insipidus, and you are preparing for NCLEX. And the trend is that you don't know it. You don't know what it is, you don't know what it means. So that's the problem. So I'm going to tell you, okay? And what's really great about knowing your medical terminology is just sometimes you can learn a lot just by looking at the name, okay? So, for instance, diabetes. When you guys see diabetes, what do you think of? Most of you are going to say, when I see diabetes, I think of hyperglycemia or high blood sugar. And that is absolutely wrong, okay? And that's a problem that was not corrected in nursing school. Diabetes, the term diabetes has nothing to do with high blood sugar. Diabetes actually means someone who is putting out a lot of urine. So diabetes is a patient who's putting out a lot of urine. The word after diabetes typically will describe what that urine looks like. So you guys are familiar with diabetes mellitus. Okay, so diabetes means somebody that's putting out a lot of urine, and mellitus means that that urine tastes sweet. Remember back in the day, they used to taste the urine to see if you had a problem with your blood sugar being too high. Okay, so when you think about diabetes insipidus, if you're thinking, oh, this patient has high blood sugar, you're completely wrong, okay? Diabetes means the patient's putting out a lot of urine. Insipidus will describe what that urine looks like. So insipidus is a term that means colorless, odorless, and tasteless. So that's what your patient is going to be presenting clinically. Now, when a patient has diabetes insipidus, they have too little of the antidiuretic hormone. And basically, the antidiuretic hormone tells your body how much urine to put out or how much to hold on to, okay? Yeah, simple. So your patient has too little of this antidiuretic hormone, what you're going to see is somebody putting out a whole bunch of urine, okay? Because nothing's telling the body to reabsorb water, okay? So patient with diabetes insipidus signs would be patient is putting out anywhere from 4 to 20 liters of urine a day. And if you think about 20 liters of urine, that is a lot of urine for somebody to be putting out, right? So your patient is going to essentially become severely dehydrated. So it's important to know the signs of dehydration, which are extreme thirst, dry mucous membranes, poor skin turgor. All right, your patient will also have postural hypotension and tachycardia. All right, now for NCLEX, you got to know how to treat diabetes insipidus. All right, and the first thing you need to know is find out what's causing diabetes insipidus, because you just don't wake up with diabetes insipidus. There's a reason why you have it. Okay, sometimes it's some trauma to the brain. Patient may have had a stroke, some tumors near the pituitary gland. All those things could be causing diabetes insipidus. So you want to find the cause and treat the cause. Now, you can also give a medication that will act like the antidiuretic hormone and tell the body to stop putting out all this urine, okay? And that's going to be like a pressing drug, like vasopressin, okay? Hear the garbage man. It's early in the morning, so sorry. So yeah, so that's diabetes insipidus. You guys will never ever get it confused with diabetes mellitus. You know the signs and you know the treatment. See you later.
So, general guidelines. Coronary heart disease is a common cause of death in people with diabetes mellitus. So encourage clients to follow a high fiber, low saturated, trans fat, and low cholesterol diet. Dietary intake should be individualized. Clients' food intake, weight management, lipid, and glucose patterns need to be monitored and standardized. Encourage quality carbohydrates, limit refined grains and sugars. Why? Because that's mostly starch, which is mostly straight carbohydrate that's going to increase calorie intake, right? Whereas something with more fiber in it isn't going to do that as much. Carbohydrates should include a minimum of 130 grams a day for healthy brain function. And carbohydrates should be 45 to 65% of total daily calorie intake. Okay. Fats. Saturated fat should be less than 7% of total calories. Trans fats, less than 1%. Limit fried foods and baked goods. Cholesterol is restricted to 200 to 300 milligrams a day. 2 or more servings per week of polyunsaturated fatty acids like fish, corn, wheat germ, and soybeans. Increase the intake of beans, vegetables, oats, and whole grains to improve carb metabolism and lower cholesterol. And recommend for fiber intake at least 14 grams per 1,000 calories. If you want to go higher, that's fine. Okay. Proteins should be 15 to 20% of total calories. So concentrate on meat, eggs, fish, nuts, beans, and soy products. Reduce protein if needed, if clients have kidney failure. Why? Because one of the jobs of the kidneys is to clear nitrogen from the blood. Okay. And of course, protein has a lot of nitrogen in it. So if you increase the load on the kidney, and the kidney's already hurting, you're going to really hurt it. It could totally click out. Okay. Eliminate tobacco, alcohol consumption for somebody who has well-controlled diabetes. Women, 1 alcoholic beverage a day, men 2. Supplements are recommended for certain deficiencies. Artificial sweeteners are fine. Consider their cultural and personal preferences, just like we talked about last week. Okay. Not all people are gonna be willing to accept just a general change in diet plan. Okay. We have to consider, what their religious background is, what their cultural upbringing is, and tailor the diet to that. The American Diabetic Association and Dietetic Association is going to have a list of daily nutritional requirements that are based on the client's needs. The dietitian is going to work and instruct the client on different methods, and maintaining that low blood sugar is the key. Okay. So again, here we're talking about primarily, right, diabetes mellitus type 2. Okay. DM type 2. All right. Type 2. Type 2 DM. Okay. And that's the kind that we can control with nutritional management, with exercise, and with meds. Okay. Type 1, you may use this to help with type 1, but the main thing for type 1, most important thing, is to take insulin. Okay. Type 1 diabetes can hit people that never even had poor diet and exercise habits. Okay. So whether you want to use these 3 keys to managing type 2 for somebody who is in type 1 depends on their overall health, right? Are they obese? Are they eating more calories than they burn? So let's say, sometimes for type 1, sometimes you don't need to do this. Sometimes you just need to take your insulin. Okay. Sometimes, right? But for type 2, always. Always. Okay. That's the key. Okay. So, 3 different diseases, right? Type 1 and type 2 diabetes mellitus are problems with blood sugar levels, but for different reasons. And diabetes insipidus is a problem with antidiuretic hormone in the posterior pituitary. And diet and exercise don't have anything to do with that. Okay. All right. So let's take 15, bump out of here. And I will see you guys at, let's just say 11:30. 11:30. All right, we're back. All right. All right. Share. And there we go. Share. There we go. Okay. All right. This chapter is very different from everything else that we've talked about in this course because it deals with providing nutrition to people that can't eat or drink, which means you're working through IV, right? And so we call this parenteral nutrition, right? This is a different kind of nutrition, okay? Parenteral nutrition delivers nutrients through IV. It's used in patients who don't have sufficient GI function in order to get their nutrients and who may get malnourished. Patients that get parenteral nutrition typically have intestinal disorders or are critically ill. Peripheral parenteral nutrition is provided to patients who need short-term support, which would be less than 2 weeks, and don't have high nutrient needs or fluid restrictions, but nutrient concentrations have to be limited to avoid inflammation of the veins. TPN, which is total parenteral nutrition, supplies nutrition-dense solutions for long-term support. This kind of nutrition may be contraindicated in patients at risk of fluid overload, severe hyperglycemia, or significant electrolyte disturbance. It's also not advised when used for fewer than a week, for less than a week, in previously well-nourished patients. Some studies have raised questions about the efficacy of parenteral nutrition for different conditions in which we used to use it. As a result, clinicians need to consult updated clinical guidelines before they use this. Once the decision to use parenteral nutrition has been made, the access site has to be selected. Sites for IV nutrition are in 2 main categories: peripheral veins located in the forearm or hand, and large diameter central veins located near the heart. As we'll talk about later, peripheral veins may be used to deliver limited amounts of nutrients for short periods, but central veins can supply all the patient's nutrient needs for a long time. Okay, so let's take a look at parenteral nutrition. Oh.
Welcome to our presentation on parenteral nutrition. We are the dietetic interns from Larkin Community Hospital. So let's jump right into it. So parenteral nutrition is defined as nutrition given through a vein. Now, in total parenteral nutrition, this is a concentrated therapy designed to provide all the nutrition that somebody needs. So it includes the 3 main macronutrients: carbohydrates, protein, and fats, which we'll talk more about later, as well as other components such as electrolytes, vitamins,
trace minerals, and free water. So when should you use parenteral nutrition? Well, consider a patient who has some kind of bowel resection, or maybe they've had uncontrollable vomiting or diarrhea. Imagine a patient whose bowel function is just not working. And here's some more specific examples of when we can use parenteral nutrition. So perhaps the patient has protein energy malnutrition, or maybe they've been NPO for at least 7 days, and enteral nutrition is not feasible.
So there are two types of parenteral nutrition. There's TPN, total parenteral nutrition, and there's PPN, peripheral parenteral nutrition. For PPN, a patient should only be given to a patient who has been NPO for longer than 5 days, but the therapy should not exceed 10 days. It is used temporarily until a central line has been placed, or any other type of nutrition is feasible, whether it is enteral nutrition or PO nutrition. If a patient is hypercatabolic with need to supplement their enteral or PO feedings, and the energy and the protein provided by PPN are limited by the osmolarity and the volume required for nutrient delivery. Peripheral parenteral nutrition is administered through the peripheral veins, and it can easily collapse if the concentration is too high. So in that case, the dextrose concentration should not exceed 10%. For total parenteral nutrition, TPN, it contains concentrated nutrients, so therefore it requires a central line.
And moving on to the components of parenteral nutrition, as stated earlier, it contains amino acids, carbohydrates, and lipids. Amino acids are the building block of proteins, which in the long run inhibit the breakdown of skeletal muscle in these patients. And amino acids yield about 4 calories per gram. For dextrose or carbohydrates, the concentration will also vary depending on if PPN is being used or TPN, and they yield 3.4 calories per gram. Carbohydrate levels are very important to know with patients on TPN, and in diabetic patients, it should not exceed 4, and in regular or non-diabetic patients should not exceed 5. And the formula is right here on the first bullets. We get the grams of carbohydrate times 1,000 divided by the patient's weight in kilograms, divided all that into 1440. Lipids are also important as they are a source of essential fatty acids and energy, and they yield about 2 calories per ml. It's important to note that lipids should not be hung for more than 12 hours, and the infusion rate should not go above 2.5 grams per kilo per day. An important note for lipids is that some medications such as propofol also provide calories derived from lipids. This is common in patients in the ICU who are under sedation. Therefore, the use of intralipids may not be necessary for these patients.
Now I'll be talking about the rate and recommended labs. So predictive equations will be used to calculate the patient's needs. We increase the rate slowly in order to prevent complications. On day 1, we'll start out with 50% of the desired rate. On day 2, we'll increase to 75% of the desired rate. And finally, on day 3, we will increase to reach 100% of the goal rate. For lab recommendations, we recommend tight controlled labs, which will include all of the following on this slide. It's important to note that all patients will get their blood sugar checked and have insulin ordered, even if they don't have diabetes, in order to help control their blood sugar. Now I'll talk about the complications. There are quite a few of them that can arise from TPN, which is why it's monitored so closely. There's refeeding syndrome, which is a syndrome of metabolic disturbances that may occur in malnourished or starved patients when feeding is reintroduced. The reintroduction of carbs into the diet causes a shift of fluid, glucose, electrolytes, and minerals into the intracellular space, which severely decreases serum levels. Hyperglycemia can result, which is why it's important to start slowly. For example, starting at 50% of the desired rate and then increasing. There could be essential fatty acids deficiency, which is caused by TPN without lipids. This can occur within 1 to 3 weeks. Therefore, lipids should be added unless contraindicated. There could be hypertriglyceridemia, which occurs if too much lipids are delivered. Triglycerides should be checked baseline and weekly. There is respiratory acidosis because an increase in CO2 production can be caused by overfeeding of calories. There may also be hepatobiliary complications like fatty liver if there are excess calories. Vitamin and mineral deficiencies can occur when the patient is not receiving a multivitamin through TPN or if they have increased needs because of their condition or wounds. And there's also an increased risk of infection in TPN. Now we will go over an example TPN calculation.
Hello everyone, my name is Trung Vo and I'll be explaining about TPN today. So for TPN we use Clinomix 525. The 5 stands for 5% amino acid, 25% stands for 25% dextrose. We need to determine the calories and protein needs as step 1. This patient needs 2090 calories, 100 grams of protein. Step 2, we need to determine how much lipids the patient's getting. We're using 20% lipids, so it's 2 calories per ml. We use a 250 ml bag, and we give it 3 days out of 7 days out of the week. So that's 214 calories per day approximately. Step 3, we need to subtract the lipids from the total calories. Patient needs 2090 calories. We subtract the 214 calories from step 2. We get 1,876 calories. Step 4, we convert the calories, 1,876 calories, to volume. In this case, we want milliliters. So we get 1,876 calories. We convert it to liters, convert the liters to milliliters. We get 1,786 milliliters. Step 5, we find the hourly rate. We have 24 hours a day. TPN runs constantly. So we have 1,786 milliliters. We convert that to milliliters per hour. We get 74 milliliters per hour. However, we run in 5 increments. So we round down to 70 milliliters per hour. Step 6, we have to check the energy and protein that this 70 milliliters per hour provides. So we have that 70 milliliters per hour. We transition that to the whole day, 1,680 milliliters. And this provides 1,786 calories because Clinomix 525 has 1,050 calories per liter. We convert this to liter and we times that by 1,050 calories. We should get this number. This is calories. We add that with the calories from lipids from step 2, and we get this number, 1,978 calories. This number, we're checking to see how much amino acid and dextrose we're getting. We have 1.68 liters, and we times that by 50 grams per liter, and we get 84 grams of amino acids. Same thing with dextrose. We have 1.68 liters. We times that by 250 grams per liter of dextrose. This is from the Clinomix 525, and we get 420 grams of dextrose. Last but not least, we need to check carbohydrate load. Carbohydrate load, all patients should have less than 5. Carbohydrate load, diabetics need to have less than 4. So we have 420 grams of dextrose. That's from step 6. We times that by 1,000, and we divide by the weight in kilograms per patient, and we divide this whole number by 1,440 minutes per day, and we should get a number hopefully below 5 or below 4 if it's diabetic.
In peripheral parenteral nutrition, nutrients are delivered using only peripheral veins. These can be damaged by overly concentrated solutions. Phlebitis can develop, characterized by redness, swelling, and tenderness at the infusion site. In order to prevent this, the osmolarity of the solution used for PPN is kept below 900 milliosmoles per liter, a concentration that limits the amount of energy and protein that the solution can give. PPN is used most often in patients who require short-term nutrition support and who don't have high nutrient needs or fluid restrictions. The use of PPN is not possible if the peripheral veins are too weak to tolerate the procedure. In many cases, clinicians have to rotate the access site in order to avoid damaging them. So you can see here, right, the use of peripheral veins, rotating the sites, right? They can get inflamed. We can have phlebitis, right? So this is quickie stuff, all right? Prescriptions for parenteral solutions are going to be for the individual patient's needs, right? So it'll vary. The solutions include amino acids, dextrose, electrolytes, vitamins, trace minerals. Some meds are added because of the potential for drug interactions, but we don't add too many because we don't want them to interfere with each other. Okay. Parenteral solutions include lipids that are called local nutrient admixtures or total nutrient admixtures, sorry. 3-in-1 solutions are all in one. Solutions that exclude lipids are called 2-in-1s. Parenteral solutions that are compounded in the hospital pharmacy are done so using aseptic technique in order to prevent contamination. Most patients meet their nutrient needs using larger central veins where blood volume is greater and nutrient concentrations don't need to be limited. Okay. This method can reliably, sorry. Oh, this method can reliably provide all of a person's nutrient requirements and therefore is called TPN or total parenteral nutrition. Because central veins carry large volumes of blood, the parenteral solutions can be rapidly diluted. As a result, patients with high nutrient needs or fluid restrictions can get nutrient-dense solutions they need. TPN also is preferred for patients who need long-term nutrition. There's several ways to access central veins. The tip of a central venous catheter can be placed directly into a large diameter central vein or threaded into a central vein through a peripheral one, like shown in here in the diagram. And peripheral insertion of central catheters is often used because it's less invasive and lower cost than if we go right into a central vein. Okay. Parenteral solutions provide a combination of amino acids, carbs, lipids, vitamins, and minerals that are best suited to meet the patient's requirements. Because the nutrients are provided through IV, they have to be given in forms that are safe to inject directly into the blood. Amino acids, for instance, are made up in solutions that contain a mix of essential and non-essential amino acids and are available in concentrations between 3.5 and 20%. More concentrated solutions are most often used for prepping parenteral solutions. Just as in regular food, the amino acids can provide 4 kilocalories per gram. Disease-specific products are available for patients with liver disease, kidney disease, and metabolic stress, but they are not often used in practice because of little evidence confirming that they are beneficial. Glucose is the main source of energy in parenteral solutions. It's provided in the form of dextrose monohydrate, in which each glucose molecule is attached to a single water molecule. Dextrose monohydrate provides 3.4 kilocalories per gram, a little bit less than pure glucose, which is 4 kilocalories per gram. Commercial dextrose solutions are available in concentrations between 2.5 and 70%. Concentrations higher than 10% are usually used only in TPN solutions. In parenteral solutions, dextrose concentration is indicated by the capital letter D, followed by its concentration in water, capital W, or normal saline, capital NS. As an example, D5W indicates a 5% dextrose solution in water, while D5NS is a 5% dextrose solution in normal saline. Lipid emulsions supply essential fatty acids that are a significant source of energy. The emulsion available in the US contains triglycerides from either soybean oil or a mix of olive and soybean. Egg phospholipids serve as an emulsifying agent, and glycerol makes the solution isotonic. Lipid emulsions are available in 10, 20, and 30% solutions, providing 1.1, 2.0, and 2.9 or 3 kilocalories per milliliter, respectively. Therefore, a half-liter container of 10% lipid emulsion would provide 550 kilocalories. The same volume of a 20% lipid emulsion would provide 1,000 kilocalories. In the US, the 30% lipid emulsion can be used for preparing mixed parenteral solutions, but isn't approved for direct infusion into patients. Lipid emulsions are often provided daily and can supply 20 to 30% of total kilocalories. Including lipids as an energy source reduces the need for energy from dextrose and lowers the risk of hyperglycemia in glucose intolerant patients. Lipid infusions have to be restricted in patients with hyperglyceridemia. There is also some concern that lipid emulsions that supply excessive amounts of linoleic acid may suppress some aspects of immune function. Daily fluid needs range from 30 to 40 milliliters per kilogram body weight in stable adults, averaging between about 1,500 to 2,500 milliliters for most people. The amount of fluid provided is adjusted according to the daily fluid losses and the result of hydration assessment. The electrolytes added to parenteral solutions include sodium, potassium, chloride, calcium, magnesium, and phosphate. The amounts infused differ from dietary reference intake because they are not influenced by absorption as they are when they're consumed orally. In the parenteral nutrition order, most electrolyte concentrations are expressed in milliequivalents, which are units that indicate the number of ionic charges provided by the electrolyte. The body's fluids and parenteral solutions are neutral solutions that contain equal numbers of positive and negative charges. Because electrolyte imbalances can be lethal, management of this by experienced professionals is necessary whenever intravenous therapy is used. Blood tests are administered daily to monitor electrolyte levels until the patients are stable. Commercial multivitamin and trace mineral preps are added to parenteral solutions to meet micronutrient needs. All the vitamins are usually included, although a prep without vitamin K is available for patients using warfarin who may need to restrict this nutrient. And that's because vitamin K promotes blood clotting. The trace minerals usually added to parenteral solutions include chromium, copper, manganese, selenium, and zinc. Iron is often excluded because it can destabilize parenteral solutions that have lipid emulsions and because some patients are allergic to infused iron. Therefore, special forms of iron may need to be injected separately. To avoid the need for separate infusion sites, meds are occasionally added directly to parenteral solutions or infused through a separate port in the catheter attached via a Y connector. The administration of a second solution using a separate port is known as piggyback. As an example, insulin is sometimes added by piggyback to improve glucose tolerance. Heparin can be added to prevent clotting at the catheter tip. In practice, few meds are added to parenteral solutions so that potential drug-nutrient interactions are avoided. The prescription for a parenteral solution has to take into account the patient's medical condition, nutrition status, and method of venous access. Parenteral solutions are individualized and may need to be recalculated daily until the patient's condition is stable. When a parenteral solution contains dextrose, amino acids, and lipids, it's called TNA, or a 3-in-1 solution, or an all-in-one solution. A 2-in-1 solution excludes lipids, and the lipid emulsion is administered separately by piggyback. Although the administration of TNA solutions is simpler because only the infusion pump is needed, the addition of lipid emulsion to solutions reduces their stability, potentially resulting in the formation of enlarged lipid droplets and particulates that can block capillaries or damage other components in the circulatory system. As a result, lipids are often administered separately when they're not a major energy source and are used only to provide essential fatty acids. A example describing a method for calculating the macronutrient and energy content of a parenteral solution was provided in the previous video that we watched. Okay, catheters. Although skilled nurses can place catheters into peripheral veins, only qualified physicians can insert catheters directly into a central vein. Patients may be awake for the procedure and given anesthesia. Unnecessary apprehension can be avoided by explaining the procedure to the patient. Catheter-related problems frequently cause complications. Catheters may be improperly positioned or may dislodge after placement. Air can leak into catheters and escape into the blood and block blood flow. Catheters in peripheral veins can cause phlebitis and result in reinsertion at a different site. The catheter can become clogged from blood clotting or from the buildup of scar tissue around the catheter tip. And catheters are also a leading cause of infection. Contamination can be introduced during insertion or can develop at the placement site. To reduce the risk of complications, nurses use a septic technique when they put the catheters in, changing tubing or changing the dressing that covers the catheter site. Unusual bleeding or a wet dressing suggest a problem with the catheter placement. A change in infusion may indicate a clogged catheter, meaning if you slow down, you may have a block. Infection may be indicated by redness or swelling around the catheter site or by an unexplained fever. Routine inspection of equipment and frequent monitoring of patient symptoms minimizes the problems associated with using catheters. The members of a nutrition support team, which include physicians, nurses, dietitians, and pharmacists, can administer parenteral nutrition directly or be advisors to other clinicians. Parenteral solutions may be initiated gradually or provided at full volume and full strength in selected patients. Critically ill patients require continuous infusion, where healthier patients and long-term users may prefer cyclics. Catheters are frequently a cause of complication, and we've already addressed those, right? Metabolic complications include hyperglycemia, hypoglycemia, hypertriglyceridemia, refeeding syndrome, and diseases affecting the liver, the gallbladder, and bone. When the need for parenteral nutrition resolves, meaning it goes away, patients are transitioned to an enteral diet, a normal diet through the mouth, right, as the volume of parenteral nutrition gets reduced. The method used to initiate and advance parenteral nutrition depends on the patient's condition and potential complications. In addition, infusion protocols vary from institution to institution. One approach is to start at the infusion site at a slow rate and increase the rate gradually over a 2 to 3 day period. As an example, 40 milliliters per hour can be infused during the first 24 hours and the volume increased to the goal rate on a second day. Another method is to give the full volume of a nutrient dilute solution on the first day and advance the concentration as tolerated. Solutions can often be stored at full volume and full strength unless there's a risk of fluid overload, hyperglycemia, or other problems. Parenteral solutions are usually infused constantly over a 24-hour period in acutely ill patients. Patients who need long-term parenteral nutrition often receive infusions for an 8 to 14-hour period only, allowing for more freedom of movement during the day. For this method, patients must be able to start and stop daily infusions without complication and tolerate the nutrient-dense solutions that allow them to meet their needs in a shorter time. Some patients may begin with continuous infusion and change to cyclic infusion as their condition gets better. Regular monitoring can prevent complications. The parenteral solution and tubing are checked all the time for signs of contamination. Routine testing of glucose, lipid, and electrolyte levels allow you to determine the tolerance of the patient to the solution. Frequent measurement of nutritional status may be necessary until a patient is stable. Rapid changes in infusion rates are discouraged in patients who are at risk of developing hyperglycemia or hypoglycemia. A patient should have adequate GI function and minimal risk for aspiration before parenteral nutrition can be tapered off and normal feeding started. Transitioning to an oral diet can be difficult because a person's appetite is suppressed for several weeks after parenteral nutrition stops. Patients getting continuous parenteral nutrition may have better appetites during the day if they are switched to nocturnal cyclic feedings before beginning oral intake. During the transition to an oral diet, a combination of methods is often necessary. Parenteral infusion are usually reduced at the same time that tube feedings or oral feedings begin, such that two methods together supply all the nutrients the patient needs. For some patients, parenteral nutrition may be discontinued soon after the patient can tolerate normal food. This method is often used for patients who received parenteral nutrition for only 1 to 2 weeks and who are well nourished before they came. A more gradual transition may be needed for pediatric patients who are older or debilitated. Patients who are without oral intake for more than 2 weeks. If GI symptoms develop, oral feeding should be limited in size or frequency until the intestines can adapt. Once about 60 to 75% of nutrients can be provided by other means, parenteral nutrition is generally stopped. Okay, so this kind of shows you how to monitor the patient during parenteral nutrition. Okay, that's a continuation of the same set of factors that you want to look at on a daily, weekly basis, and so on. Okay, as we talked about earlier, catheters used for IV can be a cause of serious complications, and we'll talk about some of the metabolic complications that result from them. Hyperglycemia, which is a blood glucose level over 180 milligram per deciliter during infusion, can occur in patients who are glucose intolerant, getting excessive energy, or dextrose, or undergoing severe metabolic stress, or getting corticosteroid meds. It can be prevented by providing insulin along with parenteral solution, avoiding overfeeding or overly rapid infusion rates, and restricting the amount of dextrose in the solution. Dextrose infusions are usually limited to less than 5 milligram per kilogram body weight per minute in critically ill patients, so that carb intake does not exceed maximum glucose breakdown in the body. Hypoglycemia, although uncommon, can occur when parenteral nutrition is interrupted or stopped or if excessive insulin is given. If the patient is at risk, they may fall into groups such as young infants. Feedings may be tapered off over a several hour period before we stop. Another option is to infuse a dextrose solution at the same time that parenteral nutrition is being interrupted or stopped. Hypertriglyceridemia can result from dextrose overfeeding or overly rapid infusion of lipids. Patients at risk include those with infection, liver disease, kidney failure, or hyperglycemia, and those using immunosuppressants or corticosteroids. If blood triglyceride levels exceed 400 milligram per deciliter, lipid infusion should be stopped. In refeeding syndrome, severely malnourished patients who are aggressively fed can develop a set of symptoms characterized by fluid and electrolyte imbalance and hyperglycemia. This happens because dextrose infusions raise the levels of insulin. That promotes anabolic processes that quickly remove phosphate, potassium, and magnesium from the blood. The changed electrolyte levels lead to fluid retention and life-threatening changes in organ systems. Heart failure and respiratory failure are possible problems. Refeeding syndrome generally develops within 2 weeks of beginning parenteral infusion. The patients at high risk are those who have experienced chronic malnutrition or substantial weight loss. Symptoms include edema, cardiac arrhythmia, muscle weakness, and fatigue. To prevent refeeding, we can provide only half of the patient's energy when they initiate nutrition support and gradually advance the dose over several days while monitoring and correcting electrolyte levels. With liver disease, a fatty liver can result from parenteral nutrition but it is usually corrected after the infusions are stopped. Long-term parenteral nutrition can result in progressive liver disease and eventually lead to liver failure. The cause of liver abnormalities is sometimes unclear. Liver enzyme levels get monitored weekly during parenteral support, and abnormal values are often seen within weeks of beginning infusion. The patients at high risk of liver disease are those with pre-existing GI or liver disorder, malnutrition, or severe infection. To reduce the risk, we avoid giving the patient excess energy, dextrose, or lipids, which promote fat deposition in the liver. Cyclic infusions may be less problematic than continuous ones. If appropriate, some oral feedings may be encouraged to reduce the amount of parenteral support necessary. Note that various critical illnesses and disease treatments can also cause liver complications, so parenteral nutrition can't be assumed to be the underlying cause. When we look at the gallbladder, this can develop problems when the GI tract remains unused for a long time. When parenteral nutrition continues for more than a few weeks, thickened bile builds up in the gallbladder and can lead to gallstones. Prevention is sometimes possible by initiating oral intake or tube feeding before the problem develops. Patients requiring long-term parenteral nutrition can be given meds to stimulate gallbladder contraction or improve bile flow and may have their gallbladders removed surgically. And then we have bone disease, right? Long-term parenteral nutrition can be associated with osteoporosis, which may be related to changes in the intake and metabolism of calcium, phosphorus, magnesium, and vitamin D. The ideal intervention varies depending on the patient. It may include adjustments in parenteral nutrients, meds, and weight-bearing physical activity. Patients referred for home nutrition support usually need long-term nutrition care for chronic medical conditions. The users of home nutrition services must be capable of learning the required procedures and managing any complications that come up. The home should be clean and have adequate storage for formulas or solutions and equipment. The cost should be clearly explained to the family who can't get insurance reimbursement. Candidates for home nutrition include for home enteral nutrition, people who have disorders that prevent food from reaching the intestine or interfere with nutrient absorption. Examples include individuals with dysphagia, which is difficulty swallowing, gastroparesis, which is delayed stomach emptying, or gastric outlet or duodenal obstructions, some types of fistulas, and pancreatic or intestinal conditions that cause malabsorption. For home parenteral nutrition, individuals who have disorders that severely impede nutrient absorption or interfere with intestinal motility. Examples include people with short bowel syndrome, radiation enteritis, certain types of motility disorders, and chronic bowel obstruction. As with the nutrition support provided in healthcare facilities, planning for home nutrition care involves decisions about access sites, formulas, and nutrient delivery methods. Users of home services should be involved in decisions about access sites, formulas, and nutrient delivery methods. Users of home services should be involved in the decision-making to ensure long-term compliance and satisfaction. Although home nutrition support can help improve health and extend life, users of these services and their families can struggle with the lifestyle adjustment. In addition to the high cost of nutrition support, home infusion is often time-consuming and inconvenient. Activities and work schedules have to be planned around feedings. Extra planning is necessary and precautions have to be taken when a person wants to travel or participate in an activity outdoors. Explaining one's medical needs to friends and acquaintances can be embarrassing. Among physical problems, people receiving nocturnal feeding often cite disturbed sleep as a major problem. Disruptions may be due to multiple nighttime bathroom visits, noisy infusion pumps, or difficulty finding a comfortable sleeping position when they're hooked up. People using parenteral support sometimes prefer infusing solutions during the day to improve their sleeping pattern. Among social issues, the inability to consume meals with family and friends is often a concern. Many individuals miss the enjoyment, comfort, and socialization they experience with food and others at mealtime. Joining friends at restaurants and attending certain types of social events may become a source of stress for people who can't eat. People who depend on nutrition support face a lot of challenges that can affect quality of life. Support group and counseling resources are available. The Oli Foundation is an excellent source of current information and emotional support for individuals who require home nutrition. What are the ethical considerations? If providing nutrition can do little to promote recovery, is it appropriate to withhold or withdraw this support? Do patients and family members have the right to make these types of decisions? How important is the input of the health professional? In attempting to answer questions like these, health practitioners consider ethical principles. First, a patient has the right to make decisions concerning his or her well-being, even if refusing the treatment can result in death. It's generally accepted that patients' preferences should take precedence over those of their healthcare provider. A patient should be fully informed of a treatment benefit and risk in a fair and honest manner. The patient's acceptance of a treatment that has been adequately disclosed is considered informed consent. A patient must have the mental capacity to make appropriate healthcare decisions. If a patient is mentally incapable of doing so, a person designated by the patient can serve as a surrogate. Ethical principles continue. The potential benefits of any treatment should outweigh the harm. Healthcare providers have to determine whether the provision of healthcare to one patient would unfairly limit the care of other patients. Although these principles may seem simple, it's often difficult to determine the appropriate action to take when doing this type of care. When clinicians and families disagree, the courts may be asked to decide. When a patient's preferences aren't known, the medical staff is obligated to provide any and all available care that's going to sustain the patient's life. Nutrition support and hydration are both considered life-sustaining treatment because withholding or withdrawing either can result in death. Other life-sustaining treatment includes cardiopulmonary resuscitation, which supplies oxygen and restores a person's ability to breathe and pump blood. Defib, which can restart the heart rhythm, okay? Mechanical ventilation, which substitutes for lung function, and dialysis, which substitutes for kidney function. Although life-saving treatments are readily provided to patients who have a reasonable chance of recovering, it can be difficult to determine the best course of action for patients who are dying or who are unlikely to regain consciousness. Under these circumstances, such treatments may be considered futile because they're unable to improve the outcome of the disease or increase the patient's comfort and well-being. If the patient or the caregivers demand treatment that a health practitioner can have determined to be useless, legal resolutions may be required. Conversely, medical personnel may find it objectionable to withdraw life support when they know that the inevitable consequence is death. Advanced planning is critical. Individuals are encouraged to discuss medical preferences with family members and surrogate decision makers so that their wishes will be considered in the event that they become incapacitated. In addition, written instructions regarding one's preferences, known as advanced directives, can be incorporated into the medical record and updated when appropriate. They take effect only if a physician determines that a patient lacks the ability to understand and make decisions about available treatments. If a person's preferences aren't known, decisions are based on a patient's best interests and are determined by a caregiver or a family member. Okay, so you can see all of these different components that go into these ethical considerations. Legal decisions. One of the landmark cases involving nutrition support concerned Nancy Cruzan who suffered permanent and irreversible brain damage after a car crash in '83 when she was 26. After she'd been in a persistent vegetative state for 5 years, her parents requested permission to discontinue tube feeding, but hospital staff didn't want to honor that request, and it went to the Missouri Supreme Court. They determined that Nancy had never definitely stated her right to die, and that her parents were unable to make such a request for her. The court also stated that preserving life, no matter what its quality, takes precedence over all other considerations. The parents appealed the ruling, but in '90, the Supreme Court upheld the Missouri decision in a 5-4 decision. 3 witnesses were eventually found who could testify that Nancy would not have desired life-sustaining treatment under these circumstances, and the court finally granted permission to remove the feeding tube. This case illustrates the importance of having advanced healthcare directives that specify your preferences for medical treatment if you're incapacitated. We call these living wills. Okay, everybody should have one. And then there's religion. The withdrawal of nutrition, support, and other life-sustaining methods may not be acceptable to persons of some religious faiths. As an example, Orthodox Jews believe that life-sustaining treatments should be continued even if a person meets the criteria for brain death. If a person's religious beliefs are not in accord with medical recommendations, health practitioners are expected to consider the person's viewpoint and try to resolve the issue somehow. If practitioners are unable to comply with the wishes of a patient or a caregiver, the care of the patient should be transferred elsewhere. And then there's advanced planning. Individuals are encouraged to discuss their medical preferences with family members and surrogate decision makers so that their wishes are considered in the event that they become incapacitated. In addition, written instructions regarding one's preferences can be incorporated into the medical record and updated when appropriate. They take effect only if a physician determines that a patient lacks the ability to understand and make decisions about available treatment. If a person's preferences are unknown, decisions are based on a patient's best interest as determined by a caregiver or a family member. Advanced directives are where a person can declare preferences about medical treatment in advance of in an advanced healthcare directive, sometimes called a living will. These directives include instructions about life-sustaining procedures that a person does or doesn't want. Another important directive is called durable power of attorney, in which another person is appointed to act as the decision maker in the event of incapacitation. The agent should understand one's medical preferences and be absolutely trustworthy. Only one person can be designated, although 1 or 2 alternates can be used. If an agent is given comprehensive power to supervise care, he or she may make decisions about medical staff, healthcare facilities, and medical procedures. Laws regarding advanced directives vary from state to state. In some states, nutrition and hydration aren't considered life-sustaining treatments, and a person's instructions about them may need to be included separately or indicated separately. Some states restrict the use of advanced directives to terminal illness or disallow them during pregnancy. Generally, advanced directives created in one state are honored in another. DNR is what we call do not resuscitate, and it's frequently used to withhold CPR in the event of cardiopulmonary arrest, which occurs too suddenly for deliberate decision making. A DNR order is written in the medical record as other directives are, but it doesn't exclude the use of other life-prolonging measures. The DNR order is most often used in patients for whom death is expected and unavoidable, such as those with serious illness or advanced age. Some institutions allow a physician to write a DNR order for a patient who has a poor prognosis, but the physician must inform the patient or surrogate if this is done. Organ tissue donation. End-of-life decisions invariably raise questions about a dying patient's preferences concerning organ and tissue donation. Even if a donor card has been signed, it's important to let family members know one's wishes, as the family may need to sign a consent form in order for a donation to happen. Although organ donation is a difficult topic to bring up near the time of death, potential donors have been assured their gift will enhance or save the lives of others. Ethical questions sometimes arise when organs are donated. A physician must alert an organ procurement team about a doctor's existence and arrange to maintain the organ function until the organs are retrieved. However, treatments that maintain the viability of organs and tissues can't be used if they can harm the donor. Sometimes the care of a donor and the needs of potential recipient may appear to be conflicting, but the care of the donors and the recipients is always kept separate and performed by different physicians. Okay, so that's a chapter or a topic that's very different from what we've looked at previously. Okay, this is a special case in which the patient literally cannot engage in normal feeding. All right, and when that occurs, then we have to go to alternative methods to prolong life. All right, and there's many considerations that come into play when that happens to be the situation. It does point out, though, that even for healthy individuals, it's important to have a living will, to provide directives specifically for these kinds of situations in the event that you find yourself in such a condition, so that your relatives or the state or the federal government isn't left guessing what it is you would have wanted. Okay, you are the ultimate determiner of your care when you're incapacitated. You make the call. Okay, and those directives and those wishes are then honored. Okay, you might remember the case of Terri Schiavo, which wasn't that long ago, where she was in a vegetative state. She didn't leave any specific directives for whether or not her life should be maintained or they should terminate feeding and respiration. And ultimately, they terminated the feeding and the respiration, and she died. There was conflict between her family, her parents, and her siblings, and her husband/boyfriend at the time, who the husband or boyfriend claimed that Miss Schiavo had indicated that she didn't want the life-sustaining treatment. There was no evidence written down that she had done that, and the family either didn't trust or believe the husband and made every legal effort to try and sustain her life. And it was a huge controversy all across the country at the time. Okay, and so what you want to do is you want to avoid those kinds of situations, right? You want to make sure that there are clear directives left for those who are around when you can't speak for yourself to follow. Okay, that's a major important consideration, even if you're totally perfectly healthy now. Okay, and it's one of the questions that you should ask a patient routinely when you're taking their medical history. Okay, that's something you want to know. Do you have a living will? Where is it? What does it specifically state? Okay, especially if you're about to be hospitalized long term. Okay, all right. Your grades are all in except for the first exam, which I'm going to put in today. The second exam, the due date was slid to this week. Okay, so it's due Sunday at 11 p.m. That's exam 2. I've sent you a practice exam 2 with a key. Okay, so I want you to study that material and then take that practice exam, see how you do, and then make sure and get practice exam 2 in. Okay, your final exam is going to be in the final week. Okay, and I will send out review material for that practice exam with the key. I'll do that today as well. And then in our last class, what we're going to do is we're going to review for the final. Okay, because we don't have any specific lecture topic for that day. It's just review. And then your diabetes assignment will be due that day, and I will send you that assignment today. And then it'll be, the thing about the final is it's going to be due not on Sunday like I normally do, but it's going to be due the following day. All right. So it's going to be due Friday by 11 p.m. Okay. And I'll update the syllabus to reflect that.
So we got to take a exam this week and then take a final exam next week.
That's correct. We have to get that exam 2 in. Okay. So you have until Sunday to get exam 2 done. Okay. Exam 2 is actually up right now. Okay. And it should be available in the calendar. And it's the same number of questions as the previous exam, but I highly suggest that after you study your material, you take that practice exam, because that will really help you prepare for the second exam. It should improve your performance quite a bit. Okay. If I have any other questions before we bump out.
So the exam is due this Sunday?
This Sunday, exam 2.
Okay.
Yeah. You got
So
plenty.
we
of time.
take the other exam.
The
We take
final,
the other exam on Thursday.
the other exam will be due the following Friday. That's the final. So it'll be due 3/12. 3/12/21. Okay. We cool? We
No,
good?
because cramming shit. Jeez.
What you say?
Any
What's
other
the
questions?
final exam is you go post it on Thursday, or is it gonna be posted before Thursday? I know it's due Friday, but when you go put it up.
I'm gonna post the final exam Sunday night.
Okay, this Sunday night. Okay.
Yeah. Yeah. So you have plenty of time to get ready.
Okay.
Yeah. All right. Any other questions before we bump?
Nope. I just want to make sure. Did you get me? Because I switched from my phone to my computer.
I got you.
All righty.
You good.
Thank you.
All right.
Have a great day.
Okay. Remember, guys, that there is Friday tutoring every week from 5 to 7. You can stop in if you need help.
All
Okay?
right.
And you should have that link. Okay.
Okay.
All right. I'll
Bye.
talk to y'all next class.
Bye-bye.
Mhm.